Okay, this is for musculoskeletal system. First thing that comes up is nerve roots. For biceps, it's C5 to C6, triceps C7, C8, knee is L3, L4, ankle S1, S2. There's a mnemonic for this. N1 to buckle my shoe, S1 to ankle jerk, it's ankle jerk shoe, 3-4 kick the door, knee jerk, 5-6 pick up sticks, biceps and brachioradialis, 7-8 shut the gate, extension, triceps. Okay, muscle root, deltoid C5, triceps C7, quadriceps L3, long flexor L8, gastrocnemius S1. And ulnar nerve arises from the middle cord of the brachial plexus and motor to the medial tropic two lumbricoles, adductor pollicis anterosi, hypothenar muscle, lumbar hypothenar, ulnar hypothenar, abductor digiti minimi, flexor digiti minimi, flexor carpis ulnaris, sensory to medial 1.5, palmar and dorsal aspects. This aspect. Patterns of damage for ulnar nerve is basically a claw hand, wasting and paralysis of intrinsic hand muscles except lateral lumbricals, wasting and paralysis of hypothenar muscles, sensei loss of the medial 1.5 fingers, and palmar and dorsal aspects. Damage at wrist is damage at wrist, and this is damage at elbow, as at wrist plus radial division of wrist. Okay. The lobe muscles can be lateral to lumbricals, opponent's pollicis, abductor pollicis brevis, flexor pollicis brevis, supplied by median nerve. It's coming up later. Well, radial nerve arises from the posterior cord of the brachial plexus C5 to C8, and extensor muscles, forearm, wrist, fingers, thumb. And sensory dorsal aspect of the lateral 3.5 fingers, dorsal aspect, the lateral 3.5 fingers, and however only small area of between the dorsal aspect of the first and second metacarpals is exclusively by radial nerve. And patterns of damage is wrist drop like this, something like that, and sensory loss to small area between the dorsal aspect of the first and second metacarpals, axillary damage as above, and paralysis of the triceps. Median nerve. Median nerve also has no voluntary motor or cutaneous function in the upper arm. It gives vascular branches to the wall of the brachial artery. These vascular branches carry sympathetic fibers, forearms. It innervates all the flexors of the forearm except flexor carpi ulnaris, and that part of the flexor digitorum profundus that supplies the medial two digits. The latter two muscles are supplied by ulnar nerve. Okay, the main portion of the median nerve supplies the following muscles. So these muscles are supplied by the median nerve: pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis muscle. The anterior interosseous branch of the median nerve supplies the following nerve: deep group flexor digitorum profundus, flexor pollicis longus, pronator quadratus. And it supplies motor nerve innervation to the first and second lumbrical muscles. It also supplies the muscle of the thenar eminence by the recurrent thenar branch. So this is the thenar eminence. The rest of the intrinsic muscle of the hands are supplied by the ulnar nerve. The median nerve innervates the skin of the palmar side of the thumb, the index and middle finger, half the ring finger, and the nail head of these fingers. The lateral part of the palm is supplied by the palmar cutaneous branch of the median nerve, which supplies the nerve proximal to the wrist creases. This palmar cutaneous branch travels in a separate facial groove adjacent to the flexor carpi radialis and then superficial to the flexor ventriculum. It is therefore spared in carpal tunnel syndrome. The muscle of the hand supplied by the median nerve can be remembered by the mnemonic loaf. For median nerve, this is loaf will be lumbricals 1 and 2, opponent's pollicis, abductor pollicis brevis, flexor pollicis brevis. So both are pollicis brevis, PB, APB, FPB, and opponent's pollicis lumbricals 1 and 2. So injury at different levels causes different syndromes. Injury of this nerve at a level above the elbow results in a loss of pronation and above the elbow. Loss of pronation and reduction in flexion of the hand. So this is pronation, and reduction in flexion in the hand at the wrist. Entrapment at the level of the elbow or proximal forearm could be due to the pronator teres syndrome. Injury to the anterior interosseous branch in the forearm causes the anterior interosseous syndrome. Injury by compression at the carpal tunnel syndrome. Carpal tunnel causes carpal tunnel syndrome. Severing the median nerve causes median claw hand. In the hand, thinner muscles are paralyzed and will atrophy over time. And opposition and flexion of the thumb are lost. The thumb and index finger are arrested in adduction and hyperextension. This appearance of the hand is collectively referred as ape hand deformity. And anterior interosseous nerve is the largest branch of the median nerve, arising distal to the lateral epicondyle. It's a favorite nerve in Mrcp. Okay, never heard of it, sadly. So it's the largest branch of the median nerve, arising distal to the lateral epicondyle. It's a favorite nerve. It accounts for less than 1% of all compressions pulses in the upper limb. So it supplies flexor pollicis longus, flexor digitorum profundus to the index, and sometimes middle finger, pronator quadrants. So the inability to oppose the thumb and the index finger, inability to flex the thumb IP joint, and inability to flex the distal IP joint of the index, pronator quadrants paralyzed. And for traumatic and non-traumatic etiology. Okay, moving to lower back pain. So it's one of the most common presentations seen in practice. While most presentations will be of a non-specific muscular nature, it's worth keeping in mind possible causes which may need specific treatment. Okay, so red flags for lower back pain is age less than 20 and age more than 50, history of previous malignancy, night pain, history of trauma, systemically unwell, weight loss or fever. So facet joint, spinal stenosis, ankylosing spondylitis, peripheral arteritis, prolapse lumbaris. So let's go with the last one, very common one. Usually produces clear and dermatomal leg pain associated with neurological deficits. The leg pain usually worse than back. Pain often worse when sitting. So leg pain often worse than back pain. Prolapse lumbaris. And so the leg pain is associated with the neurological deficits according to the dermatomes. Supplies of the lungs, of the nerves. Peripheral arterial disease, pain on walking, relieved by rest. So when you're walking, muscle is being used up, more blood supply is created, so it's like being painful. Absent or weak foot pulses and other signs of limb ischemia. History may include smoking and other vascular disease. Ankylosing spondylitis, typically a young man who presents with low back pain, and stiffness, young man with low back pain. Stiffness is worse in the morning and improves with activity. Peripheral arthritis, 24%, if more common in female. Spinal stenosis, usually gradual onset. Unilateral or bilateral leg pain, with or without pain, without back pain, numbness and weakness, which is worse on walking, results when sits down. Pain may be described as aching, crawling, relieved by sitting down, leaning forwards and crouching. Sitting down, leaning forwards and crouching is spinal stenosis. Clinical examination is often normal. It requires MRI to confirm diagnosis. And facet joint. Okay, facet joint, basically invertebrate, may be acute or chronic. Pain worse in the morning and on standing. So facet joint pain may be acute or chronic, pain worse in the morning and on standing. On examination, there may be pain over the facets. Pain is typically worse on extension of the back. So it's worse on standing, facet joint. The spinal joint is worse on walking, worse when sitting, pain on walking, worse in morning and in night. So some things you need to remember is the three actions. Facet joint, you're walking fast, facet, standing. Sorry, worse on standing. So pain worse in the morning and in standing, and there may be pain over the facets. So the standing makes it worse, and when it results when it sits down, and leg pain is there, worse on walking. Okay, relieved by sitting down, leaning forward, spinal stenosis. And worse in the morning, involves with activity, ankylosing spondylitis, peripheral arterial disease, weak foot pulse, pain on walking. Okay, so next is muscular disorders. Myotonic dystrophy, also known as dystrophia myotonica, is an inherited myopathy with features developing at around 20 to 30 years old. It affects skeletal, cardiac, and smooth muscles. There are main two types of myotonic dystrophy. So inherited. So one thing is common is D. Distal weakness initially, autosomal dominant, diabetes, dysarthria. So the 4 Ds here: dystrophy, distal muscle, autosomal dominant, diabetes, dysarthria. So it's an autosomal dominant disorder, trinucleotide repeat disorder. DM1 is characterized by CTG, Chittagong people. Repeat at the end of the DMPK, dystrophia gene on chromosome 19. DM2 is caused by repeat expansion of the ZNF9 gene on chromosome 3. So slow relaxing grip may be noticed an initial handshake with the patient and is typically of myotonic dystrophy. Dysarthric speech is secondary to myotonia of the tongue and the pharynx is the myotonic facies. And the key difference between the DM1 is distal weakness more prominent, proximal weakness more prominent. Okay, and chromosome 3, chromosome 19. Severe congenital form is not seen. So what are the features? Firstly, general features are myotonic faces, long haggard face appearance, frontal balding, bilateral ptosis, cataracts, dysarthria. So other features can be myotonia, tonic spasm of the muscle, weakness of arms and legs, distal initially. DM1 has distal more, and mild mental impairment, testicular atrophy, diabetes mellitus, cardiac involvement like heart block, cardiomyopathy, dysphagia. So these things are also involved, and it's red, so very important. Rhabdomyolysis will typically feature in the exam as a patient who has a fall or prolonged epileptic seizure and is found to have acute renal failure on admission. So it's a fall or an accident or something like that. Acute renal failure with disproportionately raised creatinine. So renal failure, elevated creatinine kinase, myoglobinuria, hypocalcemia, because myoglobin binds calcium, elevated phosphate released from the myocytes. So the muscles are releasing phosphate. That's why elevated phosphate and calcium is being used up by myoglobin, so hypocalcemia. Causes can be seizures, collapse, coma, ecstasy, rush injury, myocardial syndrome, drug statins. IV fluid to maintain good urine output. Urinary alkalinization is sometimes used. Okay, next is a very important topic, dermatomyositis, and it's an inflammatory disorder causing symmetrical or proximal muscle weakness. So this is proximal. That one was myotonic dystrophica, is like distal muscle weakness type 2 especially, and it may be idiopathic or associated with connective tissue disorder or underlying malignancy, found in 20-25% more if old age. Polymyositis is a variant of the disease where skin manifestations are not prominent. So skin manifestations are not prominent for polymyositis, and skin features can be photosensitivity, macular rash over back and shoulder, heliotrope rash over cheek, important, Cotron's papule rough and red papules over the extensor surface of fingers, nail fold capillary dilatation, malar and facial erythema, acute onset of confluent macular erythema in a periorbital and malar distribution with extension to the chin in a girl with juvenile dermatomyositis. And what is this perioral sparing? Perioral sparing will be there. Proximal weakness, muscle weakness plus tenderness plus minus, Raynaud's may be there, respiratory muscle weakness may be there, interstitial lung disease may be there, fibrosing alveolitis or organizing pneumonia, dysphagia, dysphonia. Increase creatine kinase EMG muscle biopsy. Anti-Jo1 antibodies are not commonly seen in dermatomyositis. They are more common in polymyositis. Anti-Me2 is more for dermatomyositis. Okay, so they are seen in the Paron disease, whatever. ANA positive 60%. Screen for malignancy by ultrasound abdomen plus pelvis, CT abdomen pelvis, and might be needed. Management is prednisolone. And some things which you need to remember: the skin features, since it's dermatomyositis, proximal muscle weakness, photosensitivity, macular rash, heliotrope rash, Cotron's papule, nail fold capillary dilatation, anti-Me2. Fibromyalgia. Yet another important topic, fibromyalgia is a syndrome characterized by widespread pain throughout the body with tender joints at specific anatomical sites. The cause of fibromyalgia is unknown. Pain at multiple sites, sometimes pain all over, lethargy, sleep disturbance, headaches, dizziness are common. Women are 10 times more likely to be affected. Typically present between 30 to 50 years old. Diagnosis is clinical and sometimes referred to the American College of Rheumatology classification, which lists 9 pairs of tender points on the body. If a patient is tender in at least 18 of these points, it makes the diagnosis of fibromyalgia more likely. So, management often difficult and needs to be tailored to individual patient. Psychosocial and multidisciplinary approach is helpful. Unfortunately, there is currently a paucity of evidence and guidelines to guide practice. The following is partly based on fibromyalgia Association Recommendation 2015. Explanation, exercise, cognitive behavioral therapy, pharmacological management needs tailored to individual patient. Options include low dose TCA, such as amitriptyline. SSRI can improve symptoms of pain, fatigue, and depression. SRI can cause insomnia and restlessness. Therefore, morning administration is recommended. Serotonin and noradrenaline reuptake inhibitor, example duloxetine. So TCA can be given. SSRI can be given when improve symptom of pain, fatigue, and depression. Pregabalin can be given. Tramadol, centrally acting analgesic with SNRI properties. Duloxetine like serotonin and noradrenaline reuptake inhibitors. All these things can be given. Pramipexole or dopamine agonist. Muscle relaxant like baclofen or tizatidine can be helpful with muscle twitching or cramps. Post-sleep quality is common in fibromyalgia, and hypnotics such as zolpidem can improve sleep and fatigue but do not modify pain. Benzodiazepine can be helpful for establishing initially a sleep routine, but long-term may have associated risks. Ewing sarcoma is the most lethal malignant primary bone tumor. So there's a bone, this tumor. Ewing sarcoma. Derived from the red bone marrow. It's most common in children and adolescents, that rare after the age of 30. Earliest symptoms is pain, which is sometimes intermittent but becomes increasingly intense. Delaying the diagnosis can occur due to the fact that the clinical picture may be similar to that of acute or chronic osteomyelitis. However, eventually most patients have a earliest symptom is pain, which is usually intermittent but increasingly intense. Delaying the diagnosis can occur due to the fact that the clinical picture may be similar to that of acute or chronic osteomyelitis, so similar to that. However, eventually most people have a large palpable rapidly growing mass which is tender. So it's males age more than 12, LD age high, anemia, poor response to chemotherapy. This happens in children. Okay, so common upper limb problems in Mrcp. These keep on coming, and then lower limb problems as well. Then the bone disorders, Mrcp. Common upper limb problems in Mrcp. Very important as well. One question will definitely come from this. Lateral epicondylitis, tennis elbow. Pain and tenderness localized to the lateral epicondyle, as you know. Pain worst on resisted wrist extension with the elbow extended. So when elbow is extended, wrist extension can cause pain. Elbow is extended, resisted wrist extension can cause pain with the elbow extended or supination of the forearm. There is also pain on middle finger extension. Episodes typically last between 6 months and 2 years. Patients tend to have acuprint for 6 to 12 weeks. Medial epicondylitis or golfer's elbow. Pain and tenderness localized to the medial epicondyle. Pain is aggravated by wrist flexion and pronation. Symptoms may be accompanied by numbness or tingling in the fourth and fifth medial in the finger due to ulnar nerve involvement. So medial epicondylitis, you will see Pain is aggravated by wrist flexion and also pronation. And for lateral epicondylitis, we'll see pain worse on wrist extension, and while the elbow is extended and supination is there. Radial tunnel syndrome most commonly due to compression of the posterior interosseous branch of the radial nerve. It's thought to be a result of overuse, and symptoms are like lateral epicondylitis, making it difficult to diagnose. However, the pain tends to be around the 4 to 5 centimeter distal to the lateral epicondyle, so that's the whole clue here, distal to the lateral epicondyle. Symptoms may be worsened by extending the elbow and pronating the arm, extending the elbow and pronating the forearm. So pronation is like this, not like tennis elbow, where supination is a problem. These two differences are there. Pronation can make it worse, and distal to the lateral epicondyle. Cubital tunnel syndrome due to compression of the ulnar nerve, median and ulnar. Initially intermittent tingling in the fourth and fifth finger may be worse when elbow is resting on a firm surface or flexed or for extended periods. Later numbness in the fourth and fifth finger with associated weakness. Olecranon bursitis, swelling over the posterior aspect of the elbow. There may be associated pain, warmth, and erythema. It affects middle-aged male patients. Lateral epicondylitis typically follows unaccustomed activities such as house painting. We already studied it, so it's coming back again. House painting or playing tennis elbow, as to say. It's most common in people aged 45 to 55 years and typically affects the dominant arm, characterized by pain in lateral epicondyle on passive mobilization of the wrist. So you can see tennis elbow, and there is this tendons, lateral epicondyle and the tendons there, tearing tendons maybe. And as we've seen before, like pain will be worse when there is wrist extension with the elbow extended or in supination. Management can be advised on avoiding muscle overload, simple analgesia, steroid injection, physiotherapy. Dequervancin tenosynovitis is a common condition in which the sheath containing the extensor pollicis brevis, this one, and the abductor pollicis longus tendon is inflamed, affects around 30 to 50 years old. Pain on the radial side of the wrist, and tenderness over the radial styloid process as well, this one. Abduction of the thumb against resistance is painful. So abduction of the thumb against resistance is painful. Finkelstein test with the thumb is flexed across the palm of the hand. Pain is reproduced by the movement of the wrist into the flexion and ulnar deviation. Okay. Analgesia, steroid injection, immobilization with a thumb cast splint may be effective. Surgical treatment is sometimes required. Carpal tunnel syndrome is caused by compression of median nerve. So median nerve in the carpal tunnel. So carpal tunnel syndrome is compression of the median nerve. We studied it already as well. Oh, so this is carpal tunnel syndrome. This was cubital tunnel syndrome. Cubital tunnel, U says ulnar, and carpal is like median nerve. So history: pain, spins, and needles in the thumb, index, and middle finger at night. Patients flicks hands to obtain relief. Weakness of the thumb abduction, a wasting of thenar eminence. This part, not hypothenar. Tenal sign tapping causes paresthesia. Renal sign flexion of wrist causes symptoms. Causes can be pregnancy, premenstrual edema, lumbar fracture, rheumatoid arthritis, electrophysiology, motor and sensory, prolongation of the action potential. Treatment: carpals injection, wrist splint at night, surgical decompression, all that. And then the last one, adhesive capsulitis, has a known association with diabetes. Patients typically have a painful freezing phase, an adhesive phase, and a recovery phase. Typically lasts 2 to 3 years, and in diabetic amyotrophy or proximal diabetic neuropathy or lumbosacral Reticular plexus neuropathy is a diabetic neuropathy characterized by painful muscle wasting and weakness. It affects the lower limbs and is typically asymmetric. Proximal diabetic neuropathy typically occurs in age type 2 diabetes males, though it may occur in younger diabetic patients and females. So if you think about the overall thing that happens, lateral epicondylitis it's in lateral epicondyle, worst on wrist extension with the elbow extended or supination of forearm. Okay, medial epicondylitis is when there's like pain in the medial epicondyle and aggravated by wrist flexion and pronation. The tingling in fourth and fifth due to ulnar nerve involvement. Radial tunnel syndrome is due to overuse, and pain can be 4 to 5 centimeters distal to the lateral epicondyle. It's same like lateral epicondylis but distal. And instead of supination, pronating may cause the pain. So remember RP and LS. Cubital tunnel syndrome U sounds like U, ulnar. So intermittent tingling in the fourth and fifth finger may be worse when the elbow is resting on a firm surface. Lateral numbness. All-around bursitis, there will be a posterior swelling. Okay, forearm erythema. Tuberculous tenosynovitis, there will be tenderness of the radial stellar process. Females are more affected. Abduction tongue will be painful. All that. Carpal tunnel syndrome is of the median nerve. There will be first 3 fingers will have problems. Weakness of adduction. Thinner eminence will be wasted. Renal sign positive, all this positive, and all that. So going to common lower limb problems in MRC. The lower limb problems can be common peroneal nerve lesion. So the scarring nerve divides into tibial and common peroneal nerve. So scarring nerve divides to tibial going down and common peroneal nerve going that side, lateral side. The most common characteristic of a common peroneal nerve lesion is foot drop. So other features include what? Weakness of foot, dorsiflexion. Dorsiflexion is moving down. Dorsiflexion is moving up. Plantar extensor, as in that. Dorsiflexion is same as plantar extension. And weakness of foot eversion, so moving away, weakness of extensor hallucis longus, sensation loss over the erosion of the foot and the lower lateral part of the leg, weakness of anterior tibial and peroneal muscles. Baker's cyst, most common mass in the popliteal fossa. Since the cyst is an extension from the knee, it's lined by synovium. Ultrasound is the investigation of choice in the evaluation of a popliteal mass. Complication most common is rupture or dissection of fluid into the adjacent proximal gastrocnemius muscle belly, which results in a syndrome mimicking the symptoms of a deep vein thrombosis. Doppler ultrasound will, however, show the vascular lumen to be compressible. The lumen is not compressible in DVT due to the presence of thrombus. And conditions associated with popliteal cyst in descending order of frequency. So all these things, arthritis, gouts, all these things are there associated with popliteal cyst. An ankle injury, the O2R rules for ankle x-rays have a sensitivity approaching 100%. Ankle x-ray is required only if there is any pain in the malleolar zone and one plus of the following reasons. Bony tenderness at the lateral malleolar zone. From the tip of the lateral malleolus to include the lower 6 cm of posterior border of the fibula. Bony tenderness at the middle malleolar zone. And inability to walk 4 weight-bearing steps immediately after the injury and in the emergency department. 4 weight-bearing steps. So if there is pain in the malleolar zone plus lateral malleolar zone bony tenderness or medial malleolar zone bony tenderness or inability to walk with 4 weight-bearing steps, you have to do X-ray. Ankle X-ray. A super important topic of bone disorders. Osteoporosis and osteomalacia, all these things, Paget's keeps on coming in the exams, but osteomalacia. So to keep a strong basic about regarding these topics. Osteomalacia, normal bone tissue but decreased mineral content. So rickets if when growing, osteomalacia if after FHC's fusion. So types can be vitamin D deficiency, like malabsorption, lack of sunlight, diet, renal failure, drug induced like anticonvulsants, vitamin D resistant. It can be an inherited disease. Liver is like cirrhosis. So in this thing, what you notice is calcium, phosphate are low. So important to know these things. Calcium and phosphate will be low, not normal, like in Paget's. It's low and alkaline phosphate is raised. Osteomalacia. So compared to this in Paget's, you'll see normal calcium phosphate and alpha phosphate is high. So features can be rickets, knock, knee, bow leg. Features of hypocalcemia, osteomalacia, bone pain, fractures, muscle tenderness, proximal malady. So investigation can be low calcium and phosphate, vitamin D, increased LP, extra children, cupped ragged metaphyseal surface, adults translucent bands, loses zones or pseudofractures, loses zone or pseudofractures. And treatment will be calcium with vitamin D tablets. Osteopetrosis, something different. So, aka marble bone disease, petrosis, rare disorder of the defective osteoclast function resulting in failure of normal bone resorption. So, failure of normal bone resorption. Resorption is not talking about. Stem cell transplant and intergramma have been used for treatment. As far as I know, there is no abnormality in calcium, phosphate, or ALP. Everything is normal, just failure of osteoclast. Osteogenesis imperfecta, brittle bone disease, compared to marble bone disease, osteopetrosis. It's a group of disorder of collagen metabolism resulting in bone fragility and fractures. The most common and milder form of osteogenesis imperfecta is type 1. An overview will be autosomal dominant AD or abnormality in type 1 collagen due to decreased synthesis of pro-alpha and pro-alpha 2 collagen polypeptide present in childhood, blue sclera, and deafness secondary to autosclerosis. So blue sclera and deafness, eyes and ears as well, and then there is fractures, eye-ear fractures imperfect. Just remember that. Osteoporosis, very important. Family history. Risk factors can be family history of female, increasing age, deficiency in diet, sedentary lifestyle, smoking, premature menopause, low body weight, or not obesity. And then Asians and Orientals, research is going on whether warfarin is a risk factor. So with osteoporosis, male with osteoporosis without significant history, check testosterone. So this is which predisposes to osteoporosis can be endocrine, increased glucocorticoid. Cushing's and steroid therapy can lead to osteoporosis, hyperthyroidism, hyperparathyroidism, hypogonadism, growth hormone deficiency, diabetes mellitus, multiple myeloma, lymphoma, GI problem, malabsorption, gastrectomy, liver disease, rheumatoid arthritis, long-term heparin therapy, chronic renal failure, osteogenesis imperfecta, homocystinuria. Targeting risk assessment. NICE 2017 consider assessment of fracture risk in all women age 65 years and over and all men age 75 years and over. In women age under 65 and men under 75 in the presence of risk factor, for example, previous fragility fracture, common use of or frequent recent use of oral or systemic glucocorticoids. Risk assessment: all women above age 65 and over, women age under 65 and men under 75. Okay, so previous fragility fracture, current use of frequent recent use of oral or systemic glucocorticoids, history of falls, family history of fracture, other causes of secondary osteoporosis, low body mass index, smoking, alcohol intake more than 40 units per woman, more than 21 units per woman. Do not routinely assess fracture risk in people less than 50 years old unless they have major risk factors, for example, current or frequent recent use of oral or systemic glucocorticoids, untreated premature menopause or previous fragility fracture, because they are unlikely to be at high risk. Okay, use risk factors like fracs for 40 to 90-year-old, Q fracture, take the scan, blah blah blah, all that. So for major BMD to assess risk fracture in people under 40 years who have a major risk factor for such a history of multiple fragility fracture, major osteoporotic fracture, or current or recent use of high dose oral or systemic glucocorticoids more than 7.5 milligram. Management primary prevention bisphosphonate, of course, alendronate. So this is like a picture of osteoporosis and normal bone. Bisphosphonate is a primary, Denso is an alternative. Secondary prevention, osteoporosis is defined by T-score minus 2.5 SD or below and DXA scan. Osteoporosis must sustain a clinically apparent osteoporotic fracture. Raloxifene teriparatide, vitamin D and calcium supplementation should be offered unless the clinician is confident and they have adequate calcium intake and are vitamin D deplete. Around 25% of patients cannot tolerate alendronate, usually due to upper gastro problems. These patients should be offered risdonate or etitonate. Supplementary notes on treatment like bisphosphonate, alendronate, risdonate, and etitonate are all licensed for the prevention and treatment of postmenopausal and glucocorticoid-induced osteoporosis. So, postmenopausal glucocorticoid-induced osteoporosis, you can give these three. All three have been shown to decrease the risk of both vertebral and non-vertebral fractures, although alendronate risdonate may be superior to etitonate in preventing hip fractures. Ibandronate is a once monthly oral bisphosphonate. DEXA. T-score is a SD between patient's BMD and that of a young control, and Z score is a SD between BMD of the. So this is the DEXA score. T-score greater than -1 on normal. T-score between -1 to -2.5 reflect osteopenia, and T-score less than 2.5, that is -3 or -4, reflect osteoporosis. Okay, so all three have been shown to decrease the risk of vertebral and non-vertebral fractures, although alendronate, risdonate, and may be superior to etitonate. Ibandronate is once monthly. Okay, and then there are more therapies like vitamin D and calcium. Poor evidence based to suggest decreased fracture rates in the general population at risk of osteoporotic fractures may decrease rates in fall house of bone patients. Raloxifene is a selective estrogen receptor modulator and has been shown to prevent bone loss and to decrease the risk of vertebral fractures, and not been shown to decrease the risk of non-vertebral fractures. Has been shown to increase bone density and in the spine and proximal femur. May worsen menopausal symptoms. Okay, and increase the risk of thromboembolic events. Decrease risk of breast cancer. Strontium ryanolate dual action bone agent increases deposition of new bone by osteoblasts and decreases absorption of bone by osteoclasts. Strong evidence base may be second line treatment in near future. Increased risk of thromboembolic events. Teriparatide, recombinant form of parathyroid hormone replacement therapy, has been shown to decrease the incidence of vertebral fracture and non-vertebral fractures. Due to concerns about increased rate of cardiovascular disease and breast cancer, it's no longer recommended for primary or secondary. So, breast cancer and primary secondary prevention of osteoporosis and other women suffering from vasomotor symptoms. Hip protectors are there. It's a huge topic. Fall risk assessment, no evidence to suggest decreased fracture rates. However, decreased rate of fall and should be considered in management of high-risk patients. Patient who take the equivalent of 7.5 milligram prednisone daily for more than 3 months should be assessed, and where necessary, given osteoporosis prophylactic treatment. Assessment for treatment: patients taking the equivalent of prednisone more than 5 or equal to 5 daily for 3 months, and one of the following are over the age of 65 years, have a history of fragility fracture, have a T-score less than 1.5 SD. Treatment is first line oral bisphosphonate, second line alpha calcitol or calcitriol. Patches disease is a disease of increased but uncontrolled bone turnover. It's like bones uncontrolled turnover. It's thought to be a primary disorder of osteoclasts, where excessive osteoclastic resorption followed by increasing osteoblastic activity. So increased bone breakdown is excessive, followed by increased osteoblastic activity. Passage disease is common, symptomatic only 55%. So increasing age, male sex, northern latitude, family history, positive. Only 5% of patients are symptomatic. Bone pain will be there. Pelvic, lumbar, spine, and femur. Classical untreated features: bowing of the tibia, bossing of the skull, raised ALP, calcium and phosphorus are typically normal. Skull X-ray, thickened vault, osteoporosis circumscripta, normal calcium and phosphorus combined with increased ALP. Okay. Indications for treatment include bone pain, skull or long bone deformity, fracture or periarticular badges, bisphosphonate. Give bisphosphonate, and calcium is less commonly given now. And this is urinary hydroxyphilin, which is nowadays hydroxylin. Complications: deafness, cranial nerve entrapment, bone sarcoma, fractures, skull thickening, high output cardiac failure. Usually normal in this condition. There is calcium, but hypercalcemia occurred with prolonged immobilization.